Good afternoon, everybody, and welcome to the last talk of the evening. We've got Dr. Maeve Crowley talking to us about hormone treatment and blood clots. Maeve graduated from University College Cork and did her haematology higher specialist training in Ireland. She was awarded an MD for her work on the coagulopathy associated with plasma cell disorders. On completion of her training, she moved to London, where she worked as a consultant haematologist in the Haemostasis and Thrombosis Centre in Guy's and St Thomas NHS Foundation Trust. While there, she was the lead for thrombotic thrombocytopenia purpura and developed interest in antiphospholipid syndrome and cancer-associated thrombosis. She has recently taken up a post in the Comprehensive Coagulation Centre in CUH. Welcome, Maeve. Thank you so much for doing this for us. I'll hand it over to you now.
Thank you for that kind introduction, and it's a pleasure to be speaking on this topic this afternoon. I think you probably all had a really good day, and it's lovely to be following on from Professor Nionla, who looked at kind of the pregnancy issues, and now I'm looking at kind of other women's issues related to hormones. So just this is what I'm hoping to cover today. So to look at thrombosis broadly but briefly, then to talk about contraception, heavy periods, IVF, hormone replacement therapy, and gender reassignment. So these are all kind of different periods of people's lives where they may have the option of taking hormonal therapy, and just discussing when it's right and when other things should be considered. So in brief, the body aims to keep blood fluid when it's in the blood vessels, but if a vessel wall is damaged, to limit the bleeding so you don't bleed out, a series of reactions take place with the clotting proteins to cause the blood to clot and therefore stop bleeding. So there's a fine balance between pro-clotting proteins and anti-clotting proteins. And if this balance is disturbed either way, you either get excessive clotting or excessive bleeding. So with everything in medicine, history is key. What you're trying to do is balance risk with reward. And unless we know the history and the context of the patient as a whole, we can't do this properly. So family history is really important when it comes to thrombosis, and family history rather than a history of thrombophilia. So from the way I see it, if you have a history of someone with a clot in your family, then there is a history of thrombophilia, irrespective of whether they've had a positive blood test or not. And it's the same with a personal history. If you've had a clot, then you're more clotty than someone who hasn't had a clot. So that's why we ask so many questions. And this has been borne out in studies. So if you've a family history of a first-degree relative having had a clot, your risk of developing a clot is twice that as someone who doesn't have a relative. This risk is higher if that person was under 50 when they developed the clot, so it goes up to 2.5 times the risk. Or if several relatives have had a clot, it's up to 3.9. And the highest risk is if you've had several relatives with a clot and one of them was under 50 when they developed it. Unfortunately, your risk of clotting increases as you get older. So we all hope that we will get older, and therefore everyone's clotting risk will increase. Starting with contraception. So throughout the literature, it's been shown that overall hormonal contraception seems to be one of the most effective methods. This comes in many forms: tablets, patches, implants, coils, and you need to balance why you're going on it to pick the best one for you. So there's lots of reasons to go on contraception. So it can be for contraceptives to prevent pregnancy, but lots of women go on contraception because of heavy periods, troublesome or debilitating period symptoms, acne, PCOS, an irregular cycle, endometriosis, or it can be a combination of things. And when we're thinking about what's the best contraception and what's the safest one, thinking about why you're going on it is also really important. So there's two main types of oral contraceptive pills. One of them is the progesterone only pill, so that the only hormone that contains is progestin, and that's commonly referred to as the mini pill. The alternative, and probably more commonly used, is the combined oral contraceptive pill, and this contains both estrogen and progesterone. And the estrogen and progesterone contents can range between different pills, and that's why they have different clotting risks. So if we look at European Medicines Agency data, they say that if you're a woman who is not on the pill or taking any kind of hormonal contraception and not pregnant, your risk of developing a clot every year is about 2 women in 10,000. So if we think about that when I'm discussing data as we go through, 2 in 10,000 is our risk. Different kind of pills though will increase your risk. And it's important to think about what is best for you. Broadly speaking, when we're thinking about high-risk people for contraception, we think of high BMI, current smokers, thrombophilias, and this is just looking at patients who developed clots versus controls. So as you can see, if your BMI was greater than 35, you were at much higher risk, so 3.46 times more likely to develop a clot than if your BMI was greater than 35 and you weren't on the pill. The same with smokers, the same with severe thrombophilias. So throughout the literature, when they say severe thrombophilia, what they mean is a deficiency in the natural anticoagulants. So that's a protein S deficiency, a protein C deficiency, or antithrombin deficiency. So this doesn't include the factor V Leiden and the prothrombin gene mutations. They're the really common ones, but they're not the really high risk ones. Interestingly, non-blood group O people have a different risk to blood group O because they have higher risk or higher von Willebrand factor and factor VIII levels, which are also risks for getting a clot. So in some of the studies, they looked at these. So focusing a little bit more on smoking. So obviously our lowest risk group would be people who have never smoked and never taken the pill. And so they will be, in this study, the baseline. So their risk of getting a clot will be set at 1, or we could think about it as probably 1 in 10,000. If you're a former smoker and never took the pill, it goes up a little. And if you're currently smoking, it goes up a little bit more. However, if we add the pill onto this, then the increases are much greater. So much so that if you're taking the oral contraceptive pill and you're currently smoking, your risk of getting a clot is almost 9 times higher than someone who's never smoked and not on the pill. So that's something really important when we're talking about history. And when people ask, is this person suitable for the pill or not? Weight is also really important. So again, if we look at the slim people, less than 25, who are not on the oral contraceptive pill, they will be the baseline of 1. And then as your weight increases and as you take the pill, the risk goes up. But if you look at this study, it shows that if your BMI is greater than 30 and you take the oral contraceptive pill, your risk of getting a clot is almost 24 times higher than those who don't take the pill and have a BMI of less than 25. So it's all balanced, but that's quite a significant change. Looking at thrombophilias again, because this is something people are always very interested in, other than hematologists. So again, these are what we call the severe thrombophilia, so antithrombin, protein C and protein S deficiencies. So these are rare, but they're high risk, whereas factor V Leiden and prothrombin gene mutation are common, but they're low risk. Okay, so just to keep those 2 things in mind. So a lot more people will have these issues, but they're much less likely for those alone to cause a clot. What's important is the risk doesn't add if you have a factor V Leiden or prothrombin prothrombin gene mutation and the pill, they multiply. So these are the 2 in 10,000 risk of getting a clot. If you just take the pill, you probably have 2 to 3 times the risk of getting a clot. However, if you factor V Leiden and you're on the pill, or if you prothrombin gene mutation and you're on the pill, the risk is much higher. So again, this history of the mutation or the family history of thrombosis is really important. The highest risk time for developing a clot is when you start the pill. So if we look here at odd risk of having a clot in people, the first 3 months, the risk is the biggest. So 8.1 are adjusted, and that's adjusted for body mass index and smoking. So new people to the pill, it's much higher initially. And then basically, if you've tolerated the pill for a while, especially for more than 12 months, then it's unlikely that it alone will cause you to clot. Now, obviously, as I said earlier, everyone is getting older all the time, hopefully, so your risk is increasing all the time. But generally, though, that initial time is most high risk. This isn't seen in the progesterone-only contraception. So as you can see, the risks are about the same for all the time periods, and they're also much lower than the combined oral contraceptive pill. The Faculty of Sexual and Reproductive Health have made some recommendations, and unfortunately with a lot of the recommendations, they kind of deal with one thing only. So they either deal with being overweight or obese or smoking. So we tried to combine some of those. So what they say is that if you're obese, you should be told that you have an increased risk of thrombosis just from your weight, and that combined hormonal contraception is also associated with an increased risk. It's not only associated with an increased risk of venous thrombosis, so a clot in your lung or a clot in your leg, but it's also associated with an increased risk of stroke or heart attack. And this risk is particularly high if your BMI is greater than 35. And at that point, they feel that the risk of being on the pill at that weight outweighs the benefit of being on it, and they recommend against it. However, if you're overweight, they're quite happy for you to have the progesterone-only pill, the intrauterine contraception device, or progesterone implants. So again, lots of hormonal options, and it's just picking the right one for each person. Again, I like to bring it back to people, because this is all about people with lots of issues going on. So obviously a common issue for GPs is a woman with some risk factors who is looking for contraception. So I think it's really important to look into their personal and family history of thrombosis, what age they are. And unfortunately, over 35 is considered old in this age group. If you're overweight or obese, if you're a smoker, and is there a known thrombophilia. Another group of patients who are really important is those who have had a clot and require contraception. So what is their current contraception? What is their planned duration of anticoagulation? So some people may just need a short 3 months of anticoagulation after a clot, and therefore may be able to tolerate not having a contraception or using condoms for that period. It's also important about how do they develop the clot. Was it estrogen related? Was it related to a major risk factor like surgery or a flight? And what are their other risk factors? So again, going back to age, weight, smoking. And then there's the ladies who require anticoagulation and have heavy periods. It's a really common issue. So it's important to look into, have they any underlying condition that leads to the heavy periods? What's their indication for anticoagulation? So again, is it short term, and can we manage these kind of worsening periods for like 3 months? Or is someone starting it for an arrhythmia and they're going to stay on anticoagulation long term? What have they previously used to manage the periods? So were they on the pill to manage the periods and now that's been taken away? And again, as I said, duration is important. So the WHO have done their best to try and combine risk factors and divide up different kind of contraceptive devices. And they've divided them up into kind of 4 things. So type 1 would be everyone can use it. Type 2, almost anyone can use it. Type 3, probably don't use it, but it may be acceptable in some cases. And if it's a 4, then you shouldn't use it. So if we go to the venous thromboembolism point, then what they're saying is, so apologies for this, this overlies this and you turn it. So if you have a history of VTE or you have a new clot, then they recommend against using combined hormonal contraception. But then for some people, they're happy for you to have progesterone only, and they can work down. And this, they look at many different conditions for this and advise. So it's not just you can't have this. This goes through things you can have and you can't have to try and kind of put it all in place. As I mentioned before, you're also at risk of having a stroke or a heart attack with contraception. So there was a review done, and this looked at the risk of arterial thrombosis for different types of oral contraceptive pills for women under 50, and looked like your risk of getting an arterial clot, so again a stroke or a heart attack, was 1.6 times higher if you're on oral contraception versus not being on it. And if you're on a high dose of estrogen, the risk was twice as high. So throughout this talk, you'll see that estrogen is the big issue. And the higher the dose of estrogen, the higher your risk of clotting. And that doesn't matter what the indication for the estrogen is, that is what increases your risk. I like to bring heavy periods because while they're not definitively involved, they're a really common indication for the pill, and certainly starting anticoagulation will make them a lot worse. There's no very good studies on using the contraceptive pill with a history of thrombosis if you're on anticoagulation. Many experts feel that anticoagulation probably overcomes the prothrombotic effect of the pill. So in the Einstein study, so that was the study that was used to license Rivaroxaban or Xarelto, and that looked at people with newly diagnosed clots. And when they did a subgroup analysis, so when they particularly looked at these ladies who were on contraception versus those who were not, they seemed to have a similar recurrence risk for thrombosis. So therefore it was felt that if you were on Rivaroxaban, you weren't any more likely to get a recurrent clot. However, this wasn't what the study was designed to do. So this is kind of something we used to maybe guide studies in the future, and it's indirect evidence. Practice seems to vary hugely, and there's many editorials available, but very little actually hard evidence. However, it's very common to have a lady with a new clot, which is related to hormonal therapy and with heavy periods. So you've kind of two main strategies, and as I said, there's no evidence to guide either, and you need to talk to your patient about this. So either if you're starting anticoagulation, you consider continuing on hormonal therapy while on a short duration of anticoagulation, and then when you stop, change to an alternative contraception. So if you're on the combined oral contraceptive pill, you could change to the mini pill or an implant or a Mirena coil, or you could stop hormonal contraception at the time of diagnosis and use an alternative strategy to manage the bleeding. So again, these are very personal choices, and mainly a personal choice because there's no evidence to guide what the best thing to do is. Moving on to IVF. So again, estrogen, our friend or our enemy, comes back here. So everyone has quite low levels of estrogen before you start having periods. Then your estrogen levels vary through the months. And the first big thing to cause a surge in estrogen is either a pregnancy, or if you're undergoing IVF, you need this big surge of estrogen for ovulation to get the eggs. After pregnancy, you should return to this baseline level of estrogen until you have the menopause. So looking at ladies who are pregnant, their risk of having a clot is higher if their pregnancy occurred following IVF than non-IVF pregnancies. So they're at higher risk, and it's hard to know from this data whether this is because they're a bit older, have other comorbidities, or whether it's solely the IVF, but certainly there is a higher risk. So as I said, there's an estrogen surge to stimulate ovulation to achieve eggs, which is the aim of the initial part of IVF. And if this surge is too high, generally the stimulation is stopped because you're at risk of ovarian hyperstimulation syndrome, which is associated with a risk of VTE. Interestingly, if someone undergoes IVF and get a clot, it's much more likely to be an upper limb clot or a jugular vein clot. So if you have upper limb swelling, arm swelling, or neck swelling after IVF, you need to think about having a clot. So it's not the lower limb clots or the PEs as much. And that's different to most other types of hormonal therapy related clots. Following on from IVF, as Professor Neola has imagined, dealt really well with the pregnancy section, hormonal replacement therapy is used to treat menopausal symptoms. So what the aim is to replace the hormone that the body ceases to produce after menopause. And this is namely estrogen. So symptoms that we're trying to manage would be hot flushes, night sweats, vaginal dryness, loss of libido, incontinence, and bone thinning. So all very debilitating symptoms and very distressing. So it is important to deal with them. And again, lots of ways to take HRT. So tablets are very popular. However, these are the highest dose. So like the pill, Tablets in HRT have the highest risk. You can take patches, which again, transdermal, so you get a topical therapy and it's a lower dose. You can get an implant or you can get an estrogen gel. So selecting your HRT form is important to think what you're trying to achieve with it. So what is your most debilitating symptom? So sometimes topical therapies are better, sometimes you need systemic. But again, you should talk to your doctor about this. Looking at the risk of clotting with hormone replacement therapy. So if we think that this line, I know it's a little faint, is kind of a risk of 1. So anything to the left of the line, or over here, has a lower risk of getting a clot, and everything to the right has a higher risk. So if we look at the transdermal or topical forms of estrogen replacement therapy, they veer more to the left side, so the lower risk, where the rest are all oral and they're generally more on the right side, so they're higher risk. This is also seen if we look at HRT in ladies of different ages. So kind of 40 to 54. Again, here we have the transdermal ones, which are more to the left, so we're lower risk. 55 to 64, again, more to the left for the transdermal, and for the older ladies. Weight is similar. So again, topicals veer towards the left, and as your weight goes up, again, they go more and more to the right. So you're at a higher baseline risk. So adding to that risk is a problem, but definitely topical therapies will be the safest way to proceed if you require systemic hormone replacement therapy. So there are some alternatives to HRT, and it really depends on what symptoms you have. Some are helpful, some are not so helpful. And again, I'd always advise someone to stop smoking, because that's a risk factor that you can modify. So if that's your main reason why you can't have hormone replacement therapy, then you have to decide which is more debilitating, stopping smoking or having all the therapies and not being able to take the hormone therapy. Increasing exercise and cutting down on alcohol and caffeine and spicy food can help with the flushes. Clonidine can also help with flushes. Antidepressants in some situations. So it's very much about identifying what your troublesome symptoms are and looking at anything that's a low risk strategy to alleviate them. And finally, just to look at transgender women, because this is becoming increasingly out in the open. So the goal of hormonal therapy in this case is development of secondary female characteristics. So there's fewer, if any, alternatives to this. It can put people at risk of thrombosis, but again, it's something that if people feel they really need it, we need to work around it. There's very little evidence on it, but retrospective studies show that the risk of arterial and venous thrombosis is about 0 to 6%. Again, other clotting risk factors are really important, and rates are higher with oral estrogen. So again, if you could get away with topical, that would be better, but modifying your other risks of clotting is really important. So just to summarise, hormonal therapies increase the risk of thrombosis, and this has been known since we first found the pill. It's really important to consider a patient as a whole when deciding what the best choice is. What are their comorbidities, their weight, their smoking status, their own history and their family history. It's important to consider why someone is starting hormone therapy. Is it just they want some contraception, or they want to regulate their pill? Are they having heavy periods? Are they undergoing gender reassignment? These are all very different things, and different indications have different options. If there's a transdermal route, then that should always be selected if possible, because it's a lower risk of thrombosis. People generally don't develop a clot because one thing happens. It's very much the straw that broke the camel's back. So there's lots of things that occur in our lives, some which we can control, some that we can't. So I think we need to think about them all and see what we can modify. Hormonal therapy is usually something we can control, so we avoid it if possible if you're at risk, but if you can't avoid it, use as low a dose of estrogen as possible, and a transdermal route is preferable to an oral route. Thank you for your attention. and I'm happy to take any questions.
Oh, thank you so much, Maeve. That was absolutely fantastic. Here's a question for you. On the combined pill for years, about to change the brand, will my risk increase?
So it very much depends on what the estrogen content is. It's very hard to know kind of generically. Sometimes if you're going to a lower dose, then it shouldn't increase your risk. If you've been on it for years, you've kind of declared yourself as someone who tolerates hormonal therapy pretty well, but you are older. So I would get your GP or whoever's prescribing to have a look at the doses. And I mean, why you're changing is another issue. Is it because it's no longer doing what you wanted to do? Are you having kind of problems with your periods? And is that the issue? But sometimes if you're getting breakthrough bleeding and stuff like that there, then you can be changed to a higher dose. And certainly a higher dose is generally better at controlling troublesome symptoms, but that will also come with the higher risk of clotting.
Great, thank you. And so going back to IVF, when is the highest risk time of getting a blood clot with IVF? Is it, what is it just, sorry, I probably just didn't catch it right. Is it while you're on the treatment, the IVF treatment?
So I think once you start hormonal manipulation to get the eggs, then that's when you get the first big estrogen surge, and that's because you want to stimulate the ovaries to make eggs so that you can collect them. So that's a very high risk time. But even after that, there seems to be a higher risk in IVF pregnancies than other, but that is the big kind of high risk period at the start.
Okay, yeah, that's what I wanted to check with you. Does your risk, are you that increase because it is an IVF pregnancy? That's what I was thinking. I mean, probably it could be a multiple pregnancy, which higher your risk anyway, but yeah, just wanted to clarify that. Yeah, no, there's actually no more questions here on that. I think you've really covered absolutely everything on it. The whole idea really is if you do have to take the pill, to go for a lower estrogen one or something that you put on your skin, like a patch rather than, but I mean, the patches still have risks, don't they?
Yeah, I mean, they do, they're just lower.
Yes.
And as I said, it's about why you're going on it, because if you have from a HRT point of view, if you have really intolerable symptoms and can't live your life, then there is a balancing of risk, and you can't stand at home in the cold shower all the time either. So
it's true.
And so I mean, if you can stop smoking or exercise more or lose weight, you have to balance it in your own head. Like, you're a whole person. There's never just one issue. Yeah,
I suppose manage what you control yourself, and then see, do you actually really have to have this intervention? Okay, that's fantastic. Thank you. We really appreciate your talk, and it's been really, really interesting. If anybody'd like to see the talk again, they can press on the same link that they attended on, or it'll also be available on our website in the next few days. Thanks a million.
Great. Greetings from Cork.
Stay on the line.